Good afternoon, everyone. Welcome to the virtual Lunch and Learn for One CME. I'm Susan Bray, your East Valley Direct Admit Nurse Navigator for Dignity Health and your host today. Today we have Dr. Dan Indershraw with us. Dr. Shrow is an interventional cardiologist and focused on the utilization of new device therapies with a minimally invasive approach for the treatment of valve and structural heart conditions. He is the principal investigator of the TAVR Unload for Arizona and principal pioneer and director of the Structural Heart Disease Program at Chandler Regional Medical Center and Mercy Gilbert Medical Center. Today, Dr. Shrow will be sharing some of that content with us and how it relates to your everyday practice. But first, we will go over a few housekeeping issues to make sure everyone is able to claim their free CME following the discussion. If you've joined us by computer, please put your email into the chat and we will send you an email with instructions to claim your CME. The email will include a survey which is required in the CME world to claim this credit. If you're interested in future virtual no-cost CMEs, we will keep you posted and send you email invites as they get added onto the schedule. If you're calling in, you can text me your email address to 928-699-4797, or you can email me at susan.bray, and that's B-R-A-Y, at dignityhealth.org to get the instructions sent your way. I'll also give you this information at the end of the presentation. During the presentation, you can type questions into the chat area for the question and answer session that will be held at the end of the presentation. We'll also take some phone questions to Dr. Shrow as well at that time. With that wrapped up, we'll go ahead and get to the presentation.
Oh, Philip and Spencer, they got on. Good, I just sent it to them.
We ask if just everyone can mute their devices, please.
Yes, the other girl. Can I get a Eurostita?
Okay, so we'll all mute our devices. I'm Dan Sorrell, and we're going to talk about PAD. The main thing I want to get across is screening and being aggressive about it. Next slide, please. Disclosures none. Next slide. So PAD, as we know, it presents in totally different ways. We have our gentleman on the left who has claudication, and we have a lady in the middle who has a small ulcer, but then when we're in the hospital, when things are not recognized and they progress, then we have dry gangrene there, and sometimes wet gangrene, and that poses that's a problem when we get to that point. Next slide. So basically the way that PAD works is when we recognize an ulcer, we should find the reason why we're having it. Sometimes it's diabetes. A lot of patients are told that it's all like diabetic ulcers, but many times it's below the knee and below the ankle disease, and then they end up with like an amputation, so or a BKA or an AKA. However, this could be avoided many times with the techniques that we have from an endovascular, like all the endovascular technology that's come out. That we've been very, very successful in Dignity East Valley with our limb salvage program. Next slide, please. So this slide, it's not all about dollars and cents, but what I do like to point out is the main thing in this slide, I would say, is the annual cost of the post-amputation care. So it's $49,000 per patient per year. Had those patients had endovascular intervention and limb salvage and a limb salvage program, which there are only a few in Arizona, us being one of them, it would be $600 per year. But that is priceless compared to like their quality of life. Their quality of life, keeping their legs and being able to get on exercise programs, and us kind of pushing them in that way is like, you can't even put a price on that. All right, next slide. I'm going to go through these really fast because I want more so to hear from you guys. So this slide is interesting. It's the epidemiology of atherosclerosis. So although the mortality of stroke and MI are significantly higher, and we see that all the time in our patient population, and of course me, because I'm doing acute MIs all the time as well, although my mortality is lower. But PAD with a 4% mortality, the prevalence is so much higher at 22 million. The prevalence is so much higher that actually the effect on society is significant. It's just as significant as stroke and MI. Next line, please. So this was the Partners trial. I was part of another Partners trial, which was for TAVR, but this one was done before. It was an epidemiological trial, mostly in Europe, but also in the US, but it was multinational. And it showed that 29% of the patients could be diagnosed with ABI. And that led to the guidelines that I'm going to get to in a little while, a few slides later, about how we should be screening these patients in the office, especially primary care offices. Next slide, please. And here's the Venn diagram, and here's why we need to be screening. So if PAD is so prevalent, the overlap for cerebrovascular disease and CAD is so incredibly high. And this is the reason why we have guidelines that say that if you diagnose PAD in a patient, then they should be on antiplatelet therapy. And the mortality benefit is really not from the PAD, it's actually from the avoidance of either acute MI or a stroke. But this has been very well proven. Next slide, please. So here's the problem we're dealing with. As our population gets older, we're having a very significant increase. And what I would like to note in this is I feel that women were underdiagnosed more than men. Do you want to comment on that at all, Dr. Bond, as the head of the system-wide director for Women's Heart?
Absolutely, Dr. Serrao. So as Dr. Serrao alluded to, we know that as the population in America is aging, we are most probably going to see higher rates of cardiovascular disease, including peripheral arterial disease. What we're noting is that women are being less likely to be screened, and thus they're presenting much later in their disease course. So they're presenting with something called critical limb ischemia. That's something that Dr. Serrao will be highlighting later on. And with that, they're having much higher complication rates, higher needs for amputations, higher needs for interventions, because we're not screening them as early on as we should. So with our women's cardiovascular program, in collaboration with our endovascular interventional cardiologists, as well as our vascular surgeons, we're really trying to get the awareness out there that these are the patients we want to target, both women, as well as we're seeing the same results in particularly people of color. So this is something that definitely is a public health crisis and something that we need to make changes with, but at least within our health system, we are identifying that.
So besides gender disparities, are you saying you're seeing race disparities as well?
Yeah, so there are racial disparities, very similar to that of gender disparities in the sense that primarily patients that identify as Hispanic, non-Hispanic, Black, as well as our Native American community here in the state of Arizona particularly, are less likely to be screened, and they are presenting more likely with critical limb ischemia or more advanced peripheral arterial disease. There could be a multitude of reasons why. The underlining, of course, is the societal racism that we experience, but more notably, we know the social determinants of health factor in as well. So this is something that I think in the back of our mind when we're engaging our primary care physicians and family medicine physicians, we really want to be thoughtful, especially for those higher risk patients like our diabetics, our patients with renal dysfunction, or a family history of peripheral arterial disease, to consider doing screening.
All right. Well, we'll definitely I'm going to try to get through the slides as fast as I can because I want to have a big group discussion. So I definitely want to bring that up again. So we'll go to the next slide. So here's why it's important. So if you look at PAD, that like basically PAD has a 5-year mortality worse than breast cancer and Hodgkin's disease. This is scary because it's something that we could recognize early and actually we could intervene on and fix. Problem is the lack of recognition and the need for more education like we're doing today. And I hope that you would be educating your colleagues as well. Next slide. So this has always been a major problem. So the patient's self-awareness of PAD is very low. They tend to just do less or take more breaks and not walk. Like you really have to pry them for any information that you're going to get that's going to lead you down the right path. But all of my patients, I'm in a cardiovascular clinic, so I suspect this. So everyone gets their socks taken off and taking their pulses, and I'm asking about how their legs feel. And it takes probably 30 seconds, but I've caught a lot of stuff like that. Next slide, please. So why is it important? When we catch it, we care for our patients. We really love our patients. But if patients are having claudication, they're at risk. So this is from circulation, 80% risk of cardiovascular disease. We just have to assume that they do have cardiovascular disease, and that's why PAD is such and ABI is such a good screening tool, because that is an automatic risk factor that's going to lead us to look for other stuff like calcium scoring of the heart or looking at the carotids, many things. All right, next slide. And again, so the long-term mortality. So normal people, non-PAD, they are on the national average. If you have severe symptomatic PAD, that is a very, very dismal prognosis in the 10-year term. And this was an incredibly large study. And then even asymptomatic PAD that's caught on ABI that you can do in your office in probably less than 2 minutes. That is, look at the difference between normal subjects and asymptomatic PAD. It's a huge difference and it's statistically significant. Next slide. Again, this basically shows the same thing, but like the main point is that in the primary care setting, ABI is the thing that we can do to recognize these patients early. Next slide. So predictors of PAD we already know because you guys are all doctors. you guys and gals. So hypertension, smoking, diabetes, high cholesterol. So in my office, we have our PAD patients. Their LDLs are 50 to 70. A1C is less than 7. Blood pressure per guidelines for ACC-AHA is 130 over 80 or less. And of course, smoking cessation. I scare the heck out of my patients. I tell them that if they smoke, that they're basically gonna die in a few years. Like I'm very, very aggressive with that. Next line, please. So early screening of patients for PAD. Is most of the audience, are we primary care? I'm assuming that.
Yeah.
Okay. So basically anyone over the age of 65, if they just are above 65 with nothing else, they should get ABIs. And if anyone's over the age of 50 and has ever smoked or ever had diabetes, they should also get ABIs because it's indicated by the ACC-AHA guidelines. So I do that in my office. The machine I got, it was not expensive at all. The reimbursement is like, it's warranted by the guidelines. So it's also like a revenue model for your primary care practice, but more so, you're just, like we saw, that how screening could make a huge impact on your patient population. So on top of that, you look at other things like the list, the kidney disease, or if they're having any sort of symptoms such as, cramping in the legs, or hopefully not like ulcers on the feet, but that's usually when they are in the hospital. But even poor nail growth, and you could see that if you just take the socks off. All right, next slide. So how we do it, how we do everything in medicine. So you have your H&P, and then a very good physical exam where you take the pulses and you take the socks off, and that's very important. But it's the screening techniques are painless and non-invasive. So ankle brachial index, I told you about the recommendations before. I do that quite often because, having a cardiovascular clinic, many of my patients fall under that category. I'd say about 70%. And a lot of them, if I'm very suspicious, it'll be a duplex ultrasound of the lower extremities. And then some patients, it could be either a little more invasive, which would be CT angiography, or invasive angiography if I was very suspicious that I had to fix something. Or if they have CLI, then there's no question. So this is the normal anatomy and how large the vessel should be. And we get this usually, this is more so for the angiographer. Next line. This is also for the angiographer, but I do like to show that the pedal arch, not a lot of people, can I go to the next line, please? So not a lot of people, I would say maybe 7 people in the state would do the pedal arch reconstruction. So in order to do that, you have to go like down one vessel and then up the other. And a lot of times these are chronically totally occluded, meaning that they've been occluded for more than a year. It could be 5 years. And the only way that wounds could heal, or if their numbness can go away, is if you can completely reconstruct that. And I do that, but there's only a few people that do. so what I'll say is that because we're interventional cardiologists, the arteries of the foot are actually very similar in size to the arteries of the heart. So some people who are more comfortable on the big arteries, such as the ones above the knee, are less comfortable below the ankle, and especially less comfortable like doing the pedal arch. But we do that at Dignity, and we save legs, and that's why our reputation is getting pretty big now. All right, next slide. So why are we doing this? Why are we talking to the front line? Because the primary care providers are the key to what we talked about, all those graphs before, the key to patient survival, the key to patients living longer. Because you could see here 65% of patients that are having amputations never had an ABI documented, meaning they showed up when it was too late and they lost their limb. And not only is that quality of life, it's also decreasing their lifespan. And this comes from screening. If we can screen, detect early, and fix early, that the endovascular approach has been shown incredibly successful. Next line, please. Here's one screening tool that I use. I have another one, the Edinburgh questionnaire. So they could be sitting in the lounge waiting for you, and when they're doing all their paperwork, it's a simple questionnaire, and you could see, and we could get this to you also, and it will be helpful. And if they answer yes on anything, then simply either have a very inexpensive ABI machine in your office that will pay for itself within probably a few months, or you could send it out. Next line, please. Here's what the ABI machine looks like. So this is ABI with PVR. This is a little fancier, and it shows a diminished ankle brachial index, and then at exercise, it's a critical ankle brachial index. So it gives you the numbers. So you could see on, like, especially the left is significantly worse, and on exercise, the ABI is 0.29. And I'll show you, and I'll share with you, anyone who wants it, what we do with this information. But the newer machines, basically, it's a no-brainer. It'll just tell you whether it's abnormal or normal, and it'll show you which range. And I'll go through that. Next line, please. So basically anything 0.9 or below is abnormal, and this doesn't have that, but anything above 1.4 or above, that's abnormal also, because that shows like a hypercalcified artery. So that could be a problem even though the ABI is not negative or not below what you expect. So this is the kind of flow sheet. So you do the questionnaire, and they answer yes on anything, or if they're above the age of 65, or what we talked about, 50, and ever smoked or has diabetes, they get an ABI. If the ABI is below 0.9, they have PAD. You confirm that with ultrasound, and at that point, you get them on aggressive medical therapy, and then get them into an endovascular specialist who may or may not have to intervene. So if it's above 0.9, exercise ABI, as you could see in the last slide, the difference between resting ABI and exercise ABI was completely huge. And I see that all the time. If exercise ABI is fine, then, you know, you don't do anything. All right, next slide. So the symptoms we talked about, like the majority of patients are asymptomatic. And I believe I saw a lecture with Dr. Bond that women tend to be very asymptomatic. And then a moderate amount of population will endorse intermittent claudication. And then when they go to the hospital with a non-healing wound, that's a minority of patients, but we should have never got there. So really, the asymptomatic patients are who we need to target in the primary care offices and get us all involved in a team collaboration. So this is how can they present. So there's claudication, which we talked about, and we all know the cramping, tightness, walking 200 feet, and then having to stop, and then doing that again. And there's pseudoclaudication, which we see quite often. So people have very similar pain in their legs, and we end up finding out that they have a spinal stenosis. And, you know, I think the board question is that it gets better when you walk with a shopping cart, and that's because they bend over, and that basically relieves the pressure on their spine. So I've actually heard that quite often, and I'm sure all of you have as well. So that's important to differentiate between claudication and pseudoclaudication. Next slide. And why? Because when you have true claudicants, you can see that patients don't do very well. Over the long term, the survival is significantly worse. Heart attack is the major concern. And amputation is a huge concern also. Next line, please. We could skip this. So critical limb ischemia, this is what we do with our limb salvage program at Chandler. We have incredibly good operators who would be willing to spend the whole day to make sure a patient does not lose their leg. So when they do have advanced PAD and they start getting gangrene or ulcers, non-healing wounds, then if not treated right, they're either going to end up with an amputation or you're going to have a mortality. So with endovascular intervention in an advanced center such as Chandler, we could really avoid that. And we've just, I mean, it's been amazing because it's not just avoiding the mortality, it's the quality of life and the appreciation of the patients and the whole team. Next line. And this is why, because the impact of amputation essentially is that, I mean, who cares about the cost? It's really about the way that the patient can live and how hard it is to not have a leg, and also how much that it could decrease their lifespan. But here's other, you know, financial stuff that I got from all the papers. Next slide. And this is what we're really talking about. So if you look at the 5-year mortality, if you have critical limb ischemia, it's worse than things that are scary, like stroke and colorectal cancer and breast cancer, acute MI. So PAD leading to critical limb ischemia has a significant impact on the longevity of our patients' lives. Next line, please. So yes, that So angiograms are completely underutilized. So basically anyone who comes to Chandler, it's a rule now, and it should be a rule in every hospital, that if a patient is being considered for amputation, either BKA or AKA or transmetatarsal, anything, that they have to call us, and we will do an angiogram beforehand, because a lot of times we could reduce the level of where the amputation is going to be. For instance, if they have below the knee disease, we could open up 3-vessel runoff to the foot, and instead of getting a BKA, so they have to have a prosthetic, we could limit it to a toe amputation. So that's incredibly important. My phone got a little messed up here. Can you still hear me?
Yes.
Okay. So now I can see it. So as we can see, because of all of these programs and like not just us, but across the country, endovascular work has gone significantly up. So now we're not doing surgery, we're fixing things from the inside, and we're doing it very successfully, and the technology has improved. And as a consequence of this, the surgeries have gone down, but also the amputations have gone down. And it's because we're revascularizing patients and then getting them on exercise programs that keep those vessels open. Next slide. And this is showing very similar data, which basically the amputations are going lower, and it coincides with us doing more endovascular stuff. All right, we can move on. We can move on this. I think we all know lifestyle changes. We do that with all of our patients. Medications, which include, so we know that Plavix, we already talked about, and aspirin. However, like now we have emerging medications that have good data, which is low dose Xarelto, 2.5 or 5 milligram. That's BID. And we also have data on Repatha, the PCSK9 inhibitor, and that's for PAD patients. And then revascularizations, we talked about that. Let's continue. I want to hear from everyone. So, I mean, let's continue. All right, so here's our options. I think the main option lies at the top is percutaneous intervention. Stents, we rarely have to do. I don't do any stents below the knee. I only do balloon angioplasty, and then anything below the ankle. The ankle, I do balloon angioplasty. I think that stents, the data is pretty much for iliacs, and then if you really need to, you could do it for the superficial femoral artery. However, I try to avoid that. But while we're doing that, we do atherectomy, laser, like we clean out all that stuff. So here's why we like to do it endovascular, because there's less risk, patients like it better, length of stays better, and they get back to their normal life faster. This is also why we don't do surgery. They have high, I'd say like the main thing is the wound complications. So the bypass surgeries, I know that there's a lot of vascular surgeons that still do that, but I believe that's going to be less. And I think the next slide shows it pretty. So basically, what would you prefer? So on the right is a femtibial bypass, and the right is a percutaneous sheath that we could do everything that and completely revascularize. So this is, in summary, I hope I got the point across that many of our population and our community have PAD, and we have to look for it. And I think that the best strategy would be that those at risk, and we talked about the risk, the ABI is painless and very effective, and you can find so much stuff. And when you find it, you can help these patients out for the long term.
Thank you so much, Dr. Serrao, for that wonderful lecture. We do have one question in the chat, which was by Dr. Frederick Liu. His question was, what is the equipment you are using for screening ABIs right now?
So I got I could get that to Dr. Liu, but my ABI machine, it cost like $5,500. And it basically just, even a medical assistant could do it. Not even, but my medical assistants are excellent. And the reimbursement for each test is about $90 in Arizona. So it ended up paying for itself within, I'd say, about 3 months. But out at the exact company, I don't know, but I could definitely find out if you give out my email.
Now, one question that I'm always asked as a cardiologist is that once peripheral arterial disease is diagnosed, at what point do we decide to proceed with a endovascular intervention, such as getting you involved, as opposed to a lot of what the guidelines suggest, which is aggressive lipid management, getting them on antiplatelets, making sure their modifiable traditional risk factors are optimal, and considering an exercise program. If you could perhaps touch upon that.
So, all right, if a patient has an ABI under 0.9 or above 1.4, so it's in the abnormal range, then I would get a duplex ultrasound and then look for triphasic versus biphasic or monophasic flow, which the radiologist could do, or obviously you could do as a cardiologist. And if those are abnormal, then definitely an endovascular specialist, at least for an opinion, because my opinion might be, well, we'll do a CT, or no, like we're going to go straight to the cath lab and we're going to have to look directly and most likely intervene. So I think that the screening test is in that order is ABI and then duplex ultrasound, or get the endovascular specialist involved earlier. And it's much better to do. The good thing about the screening is it could be done based on the guidelines before patients have symptoms. So you can catch stuff before you have chronic total occlusions, meaning that they're at risk of amputation and gangrene, but it could have been caught. And that was the whole point of the huge partner study that was done, that big epidemiological study.
Thank you so much. And it looks like we do have a question from our solo orthopedic surgeon, Dr. Danton Dungy. His question is, if I see a patient who is asymptomatic regarding PAD, but an x-ray is performed of their knee or hip because he is an orthopedic surgeon, and that shows hypercalcification of the arterial vasculature, should he be sending this patient to you for a cardiac or carotid evaluation?
Yes. I mean, as an orthopedic surgeon, you're probably way too busy to order ultrasounds of the neck and ultrasounds of the legs and then communicate that back to the patient, because you're going to be in the operating room all the time. And I know you by reputation that you're very busy because I've heard your name before. So I would say that either vascular surgery or interventional cardiology, we will do that kind of like boring work for you.
So what I can say to that same point is calcification of the arterial vasculature usually implies plaque, right? That's plaque that's hardened over. So by definition, this patient has been diagnosed with peripheral arterial disease. We as cardiologists will make the call on, do we need to proceed with a carotid Doppler or perhaps a calcium score? Because the fact of the matter is they have PAD and we should treat them as such. Really what we would be focusing in on is the patient symptomatic from the PAD. If they're asymptomatic, then we would absolutely want to get them on an antiplatelet like a baby aspirin. We would want to make sure that, as Dr. Serrao alluded to, that their LDL was very well controlled, either between 50 to 70. And with our newer lipid lowering agents, we absolutely can reach that target, even if statins, the highest tolerated statin, doesn't get you there. PCSK9 inhibitors have exceptional data in terms of cardiovascular outcomes. We have newer agents out there like bempedoic acid, which, although we don't have to date cardiovascular outcomes, we know that they're probably going to be also very good just because they have lowered LDL substantially. And to the same degree, as Dr. Serrao mentioned, perhaps even the use of Xarelto. So for this particular patient, that would be a very key patient to get plugged into a cardiology clinic. Another question that Dr.
I have to completely agree with you on everything you said.
Perfect.
And, it sounds like they need to go to you because you know your stuff.
No, so I am a preventive cardiologist. Dr. Serrao is an interventional cardiologist, but we collaborate so well together, and we do share and co-manage our patients very nicely in terms of just the aggressiveness of it. So once we do diagnose peripheral arterial disease, if the patient needs to have an intervention, he'll do the intervention, and then thereafter, our hope is that we will prevent another occurrence, and that's where the aggressive lipid management, blood pressure management, and sugar management comes into play. So there is another question from Dr. Akinbi. I'm so sorry if I didn't pronounce that properly, but is this patient population getting access to acute inpatient rehabilitation, Dr. Serrao?
So the Dr. Akimbi is the head guy for our rehab that we send all our patients to, and we've sat on many meetings together. So these patients, it depends on how much work we have to do. A lot of them are basically outpatient. It's either overnight and many times same day. If it's critical limb ischemia, then of course they're going to have to come over to the, I don't think acute rehab, I would probably say subacute rehab.
And to that point, can you maybe differentiate the exercise programs that are suggested by the American College of Cardiology for peripheral arterial disease, and how even our cardiac rehab program may benefit these patients at Dignity?
Yeah, definitely. So all the patients are sent to cardiac rehab. So they need to have weight-bearing exercise meaning bicycle is not going to work. And so weight-bearing exercise against gravity promotes collateral flow to the legs, and it also promotes, when we do intervene on the arteries, it keeps them open. So swimming doesn't work and bicycle doesn't work. They have to actually be on their feet, and they have to be on their feet, and they have to be walking with brisk circulation with an accelerated heart rate for 30 minutes per day. And my patients, I basically say every day. But if they were to do 5 times per week, I would accept it, but I'm a little more strict on that. And that has been shown to keep the arteries open, but more so to promote collateralization of those arteries as well, so they have different bypasses of blood flow.
And just with the advent of COVID-19, how have you, in terms of making sure that we're providing care for these patients, how have you handled that situation? Has it factored in, do you believe, into screening opportunities, especially as we know COVID-19 is not leaving us anytime soon? So I just wanted your insight with that.
Well, cardiac rehab is opened up again. They are limiting the patients to half of what they did before so they could keep everyone separated. I personally, this is only my personal opinion, and everyone obviously knows enough about it to make their own opinion. I don't utilize it right now because when people are on the treadmill or they're exercising, the distance with droplets, and many times these patients are very freshly out of the hospital, which luckily Arizona, the numbers are going down, but still, we were a hot zone. So right now I have not been utilizing that. But I have been very aggressive in having my patients do outpatient exercise in a non-enclosed area.
Thank you. And I see that we do have another question from Dr. Dungy. So do the calcified plaques break off or dislodge, and do they lead to any distal occlusion as the vessel narrows? He's particularly asking because some of the orthopedic procedures that he does on hips and knee replacement either have tortuous or deformed. They could potentially torque or deform the arteries during surgery. And is there anything that he should be doing before proceeding with surgery on these hypercalcified patients?
So very calcified lesions means that there's disease there. So there's obviously a risk of that. It would be rare from an orthopedic surgery. It's more so that if we were kind of mucking around inside of the vessels, that we could dislodge a plaque, and then, which actually happens, we see it quite often, and then we have to go in with thrombectomy catheters and sometimes TPA. But if you were not in the vessel itself, external compression of the vessel, that would, to me, it would not at all cause any sort of plaque to dislodge. This is more so when you do it from the inside, when you're in the vessel and you're scraping the wall.
And maybe another question, Dr. Serrao, would be is if a surgeon does see patients that have hypercalcified arteries in their lower extremities, would this be a patient that you think would have perhaps a different preoperative risk assessment that you would want them to refer to cardiology for?
Yeah. So, all right, if they had calcium in say the iliacs on a pelvis x-ray or something like that, or a CT, then that's a CAD equivalent. So that's the same way as diabetes is a CAD equivalent. So they are at higher risk for general anesthesia, and they would need to be optimized, and they would possibly need to have a stress test beforehand. Do you agree, Dr. Bond? I know you do a lot of this stuff also.
100%. So again, by definition, PAD is the equivalent of CAD. So if you have plaque in the arteries of your legs, you have to assume that there's plaque in the arteries of your heart, and that patient may be in a slightly higher risk category when it comes to elective procedures. And it would be pertinent that a cardiologist evaluated them, at minimum got a baseline electrocardiogram, and then depending on their symptoms, their risk factors, decide on doing an echocardiogram, possibly a stress test. Again, it all depends on their symptomatology.
Yes, I agree.
Perfect. Are there any other questions?
All right. Well, thank you for having me.
I think that's Susan. We're going to hand it back over to you so you can just close things off for us.
Okay, thank you for everyone. Thank you for joining us. That wraps us up. We'll let you get back to seeing patients. If you're interested in other no-cost CMEs, Dr. Rachel Bond's 3-part series and Dr. Shroud's series presentations are on the East Valley Dignity Foundation webpage for your viewing and free CMEs. Please make sure that you receive the instructional email, and if not, get in touch with me at 928-699-4797, or you can email me at susan.bray@dignityhealth.org. I'll keep the Zoom on for a few minutes if anyone's having problems or if you have any more questions.
I actually do see a question, Dr. Serrao, if you're still on. If not, I can answer it from Dr. Dungy. The question was related to genetics, particularly as we talked about hypertension, diabetes, high cholesterol, and more of those traditional risk factors as putting one at a higher risk for PAD, but what role does genetics play? I do believe Dr. Serrao may have signed off, but I can answer that question for you. Genetics absolutely does play a role. So when it comes to family history for cardiovascular disease, if you have a first-degree relative before the age of 55 in men or before the age of 65 in women, that can absolutely put you at a higher risk for cardiovascular disease, which includes peripheral arterial disease. So when we're taking a history, we want to make sure that family history is part of that. So hopefully that answers your question. And if you have any more questions, please feel free to reach out to Susan, and she can absolutely get you in contact with both myself or Dr. Serrao. Thank you guys so much for joining in.
Thank you.
Thank you.
Thank you, everyone.
Bye-bye.